Hello, my name's Alison. I'm not a clinician, I'm a researcher. And as Andrew said, I've actually been part of a team of 4 from the Institute for Employment Studies that's been undertaking an independent evaluation of the health coaching programme as implemented so far. The Institute for Employment Studies is actually an independent, not-for-profit organisation, and we do a lot of work in the area of employment and human resource development. And my particular area of expertise is in coaching programmes. I've done a lot of evaluation of coaching programmes, but they've tended to be in the past, in this country, in leadership contexts. And it's absolutely fantastic. I was so excited when I heard that there was the first large-scale intervention attempted in health coaching, because I hear all about it from colleagues in the States and Australia, and it's about time it hit here. So I was very excited to be involved in it. So I thought I'd tell you a bit about the aims and design of the evaluation. And the way we've conducted it is it's been a deep dive study into 5 case study organisations. So I'm going to tell you a little bit about how they've gone about implementing it, and also share with you some clinician views of the usefulness of health coaching. And then finally, a bit that I know some of you are particularly interested in, which is I'm going to tell you a little bit about potential impact on patient throughput and healthcare costs. Questions that were set for the evaluation is, how has healthcare been implemented locally and within what context? Question 2 for the research, for the evaluation research, is health coaching perceived as useful for clinicians and their patients? Question 3, is there any local evidence of impact? So, not surprisingly, that reflects the structure of the presentation. Now, this is the evaluation logic model we started off with, and can you read that? Okay, well, I'll talk you through it instead of pointing at it in that case. From left to right, the blue blocks are the central things, the columns going through the middle where the arrows are. And with professionals and clinicians like yourself, we'd expect this to start with awareness about health coaching, initial training, these initial 2 days, and that is the bit that I'm talking about in terms of the training intervention that we've been looking at. The 2 days is actually quite a small intervention. So then we're looking at mindset change for clinicians and changes in your practice. So that is where the coaching intervention comes in, if you're coaching your patients. And then under the green, the final 3 columns are about the changes we would expect to see in patients. So if this health coaching intervention is working, we would expect to see, we expect to hear clinician reports of increased confidence in patients to make changes, things like increased motivation to self-manage, and increased changes in behaviour. Then if you go down to the very bottom, it's the types of evidence that the sources of evidence and the types of evidence we might look for. So the evaluation methods were a combination of qualitative and we planned quantitative. So in this is a deep dive into a number of organisations. So obviously we're not talking about an RCT here, we're not talking about control groups, we're talking about exploring the way it's been implemented and seeing what lessons can be learnt from that. So we did initial scoping focus groups with a number of clinicians, and that was when our first challenge arrived, really, in terms of the evaluation. We realised we couldn't do a primarily quantitative evaluation, as the clinicians at the initial training weren't attending as a team, and they told us in their organisations they weren't targeting specific patients or with specific conditions in any kind of a systematic way. So that was when our focus did shift much more down to the qualitative side. But ideally, what we had planned to do was to try and get some patient voice into this as well, by designing some patient experience surveys. Those have been designed, but 3 of the 5 deep dive organisations initially agreed to do them with us, but sadly, for a variety of reasons, none of those actually happened. So that's why patient experience surveys are in grey. And that's a big blow to the evaluation, to not have patient voice, because a health coaching conversation involves at least 2 people, does it not? Okay, but what we have got is a lot of clinician self-report data. And so that in its own right is very useful. And we have managed to work with just one of the organisations to look at, to help them interrogate some of their management data. So that's what you'll be hearing about. So an overview of the sites, 5 selected for different clinical settings, community services, 95 clinicians trained, CCG commissioner, 36, primary care, general practice. The organisation that was very keen to work with us managed to actually get 0 people trained, and I'll come back to that. But so instead, we talked to a number of GPs and nurse practitioners from other practices. So we have got some feedback from the sector, but not from that setting. Mental health services organisation got 33 for the training, and the acute services organisation 39. So with the exception of the GP practice that we worked with, actually quite high numbers in terms of a percentage of the overall. The first organisation might sound a bit familiar to people who were in this room for the last session. So the left-hand side of this slide and the subsequent slides are about the process of implementation, the major steps that we perceived they took. The right-hand side is about some of the lessons that I think that you might wish to bear in mind if you're going to start rolling out in your own organisations. So this particular organisation, I think if I say it was about culture change, that implies a radical change in culture, and it wasn't that. It was more, we want to extend our clinical culture here. They cast the net very widely, sent a lot of people initially for training, and then those people came back and said, do you know what, this is brilliant. I want you to go to my colleagues, let's get more colleagues going. So it was clinicians selling the concept to their peers. They then were very proactive in getting support from senior stakeholders in the organisation, and are now planning to roll out widely, and as I understand it, in a priority order for priority services. And the next step is plans to document the evidence locally. Now, I think it was a really overwhelmingly positive reaction at this organisation, and I think there were a number of factors I would say have really helped. One of which touches on actually what Matthew Wynne said earlier. I think this was a health coaching friendly organisational culture in the sense that it was a fairly open culture. There was a focus on innovation and support for learning. So you come back from training about health coaching and you have the opportunity to use those skills and to be supported in doing so. And that isn't true of all the organisations that we followed. Also, having 5 trainers, that's a typo. It says 6 trainers, it's 5 organisations. 5 trainers in one organisation gives you the opportunity for mutual support and to generate momentum to keep going. I think if you're a single trainer within an organisation, it must be quite isolating, potentially. However, having this cadre of trainers does mean that you've got to put local resources in. It's not just some free good compared to bringing in an external training organisation. But, you've all got jobs. If you're training, there are issues potentially of backfill that I don't think were totally thought through at the beginning. But of course, these things can be resolved as you go along. So that's just an introduction to one of the organisations. I've already said to you that the surgery that we were very keen to participate, in the end weren't able to send anyone. They had actually a very, very well thought through research project type approach. There were clear links to self-management, patient partnership, and their goal was to reduce the average number of appointments per patient, especially for those with long-term conditions. The average number of appointments they had per patient was 4 per year. The average for people with long-term conditions was 8 per year, and that was the number that they wanted to get down. So they designed a test pilot. IS actually helped them develop patient questionnaires, patient experience questionnaires, that in fact they didn't use in the end, but are available through the health coaching website. So if any of you want to go down that route, it's a resource that's there for you to use. Well, why didn't the clinicians go through the training? Well, it's all the barriers we've been hearing about during the day, and especially in the session that I was in earlier. Because we then spoke to 3 GPs and 2 nurse practitioners from other practices, we found the same. We sort of started to get a bit under the surface of it. And for some people, accessing 2 days of training can be really difficult. In the practice we were working with, it was a small practice in an urban area. 1 GP left the situation, and there was just everybody else had to fill in. Nobody could take any time off at all, and that went on for an extended period. So they were not willing to release anybody from that practice for what turned out to be quite a long time. Other people that we spoke to, though, said that, you know what, a 10-minute appointment is not very long. But there was a mixed reaction, because the people who really embraced it said, you know what, 10 minutes is fine. If you've got a mindset of health coaching, it's easy. But the people who said, no, health coaching is a set of tools I can use in a specific circumstance, 10 minutes wasn't long enough to use each of the tools. So it all depends, I think, on how you perceive it and how you take it on. But do you know what? There were lots of examples of successes with patients that people were able to point to. Another one was to try and get at general practice through a CCG commissioning perspective. And this was also quite a well thought through approach. There was a clear link in this case to the commissioning priority of integrated care. It was about targeting the right individuals. So there were 20 practices within their area, and they looked at picking the best person they thought they could from each of those practices. They had a high degree of success in take-up, much higher across the practices than we saw in general practice, where you didn't have a CCG promoting it and encouraging. So I think, that obviously I would say that makes a big difference. They persuaded people to participate, but now I think they want to review what the data is and get their heads around outcome measures for this. So they haven't actually decided how they're going to roll it out yet. But they did have good take-up. The people that we spoke to, they would like to see some refresher training so that they can hone their confidence and skills and keep up their personal momentum. There was some suggestion that awareness training for people who don't need to use it but need to know what it is, that would be good. And yeah, if you're a trainer on your own, it's quite a daunting prospect. The Mental Health Services Organisation, this was all about skills. There was an implementing recovery model going on in that organisation, and there were links to new ways of clinicians working. So they targeted nurses first of all, and then IAPT practitioners, and they're now considering a big rollout and linking it through their HR strategy. But there were some difficulties in transferring the learning. But I mean, if you think about it, you know, if you go on a 2-day soft skills training of some other sort, you know, how easy is it then to come back and use it in your organisation? Well, I think I said before, if you've got a supportive organisational culture, it's a lot easier. This organisation had a very difficult context at the time. They had just rebanded a number of their nurses, downgraded them, and there were also job losses. The fact that there were going to be job losses had just been announced. I would say no matter what course you're on, that's not a great context for taking on new learning. So, you know, I think there is a timing issue with this. Acute services actually had the most difficulty in terms of individuals being able to transfer their learning to their daily roles. And I think a lot of people said, well, this is just a training intervention, this is a set of tools, we're going to target specialties with longer patient interactions. So they targeted renal nursing team, research nursing team, and hand care specialists. They were going to then move to looking at multidisciplinary teams, but in fact that hasn't happened. They haven't any plans at the moment to roll out further, and I think that's because they're going to need to put in some more local support in order to help individuals, especially if there are quite a lot of what I would call low job autonomy roles in that sector, so I think it doesn't land quite as easily. Some individuals also had a concern over using health coaching in areas that lacked privacy. Okay, so the second research area for us was about what do clinicians say whether this is useful. Right, 2/3 of the clinicians we spoke to, so that's 54 different clinicians, some of whom we spoke to shortly after their training, some of whom we spoke to a second time 6 months later. 2/3 of those not only got the idea of health coaching, but had used it, were continuing to use it, and said it was really useful. In my experience of evaluating interventions, that's high. After a period of time, that many people who get it, who are using it, who are saying it's useful, I recommend it to other people. Having said that, there's a spectrum of usefulness from this is a light bulb moment, this is totally new, it's totally changing my practice. In the previous session, one of somebody said, I realise I've been doing it wrong all this time, or it's time to try something new. There's a spectrum for that too. Well, you know, it's fine, it's good, and it is making a difference, but it's a supplement to what I already do. We heard of it being used with a wide variety of patients and conditions. We've had a number of reported benefits, and you'll be pleased to hear that they are along the lines of those claimed benefits that should be arising from health coaching. And this is what clinicians said the benefits for themselves were: reduced caseload, less pressure and responsibility for patient progress. We didn't get reports direct from patients in this evaluation, but the clinicians reported increased confidence, gives power and control back, it's, you know, feel like you've got more personalised advice, enjoying life more, and other things. Now, the benefits reported to the NHS I'm going to talk a little bit more about in the remaining time, because I think that's possibly where we have a little more to add to the story. Now, higher patient compliance, reduction in episodes of care, reduction in appointments per patient. Now, that's interesting, we'll come to that. Potential to cut waiting list times and acute admissions. So, we heard this morning that the evidence review, as part of this project commissioned from the Evidence Centre, said the biggest gaps in the literature on whether health coaching reduces healthcare use or costs. Now, none of our sites set up research actually to look at this. So instead, we decided to go to explore the claims made by two individual clinicians about this. So the first claim was made by a number of clinicians. Because I'm working more effectively, I'm getting through my caseload quicker. I'm discharging people quicker, they're happy, they're confident, they're self-managing, so I'm getting through my list. So we asked her to do an audit of the departmental records to check that her gut feeling was backed up by the facts. And it was, I think, even higher than she expected. It was a 51% in new patients on her caseload, and I'll show you what that looks like. Right, we're talking about a community services setting, a physiotherapist who in fact is here today in the room. And we asked her to check the number of appointments in the 6 months prior to her going on the health coaching training and the 6 months following the health coaching training. And as you can see, her gut feeling that she was taking on lots of new patients, that's here, was correct. She'd also told us that she didn't feel as stressed and she wasn't having to do work in time that she didn't have and that she felt it was within her reach. So yes, that's also borne out by the fact that she's doing less appointments overall. So you might say, well, that's less efficient. But the difference is coming from the smaller number of follow-ups, of course. So she was right. She's taking on more new patients. And she's also right, she's doing less overall. So you can interpret this graph in many ways. I've been told to hurry up, so I'll do that. I will say that the second claim was related to this, and it is the last slide, which is that she was saying that she reduced the average time to treat each patient. So what we did is we worked with the local trust and we said, okay, well, let's work out the actual cost of that reduced time. So there was a comparison between using the usual approach on a patient, a COPD patient, which was judged ineffective by the team. Let's try something new. We'll try using a health coaching approach, which did achieve successful objectives. So we were able to directly compare that with the same patient. Okay, we're talking about one case, I realise that. But it's interesting because when we worked it out, there's a 63% indicative cost saving when comparing those two approaches, one of which was deemed successful, one of which wasn't, in this case. Well, that sounds like a lot. The next thing we did was say, well, what would that mean for this one clinician over the course of a year? She was part-time, so we had to work it out and make it up to a full-time equivalent. So you're looking about £12,500 for one clinician with, over the course of a year. However, of course, that's a big stretch because it assumes that the reduced clinical time is replicable across patients and sustainable over time, and we don't know that either of those things are the case. But so I just wanted to say, though, that I think it's an interesting place to look further at. And the implications of that for her service are that they have a waiting list, so she's going to get people through the waiting list quicker. Potentially, this means that your services could cope with rising demand with the same number of resources if you're getting more people through. But it also means that you could get people off a waiting list quicker. So, I think there's an awful lot of, we found an awful lot of potential here. So in summary, the clinicians we spoke to perceive health coaching is effective. 2/3 of them are using it, which is quite a high penetration. and they can point to multiple benefits. They have stories of success that you can tap into. So I think the 2-day training intervention is working. However, there are some implementation issues. It's not been able to be adopted by people in every context. I would say there are culture and work context issues, and those are key to success. So for those rolling it out, mentoring or coaching, I think, probably is needed. Finally, I would say it's too early to say if the train-the-trainer model and the current numbers will deliver sustainability. But, I think it's overall very positive. So thank you very much.